this week on the BackTable podcast.
If you can find a way, that happy medium where you're doing something that's really helping someone and it's also a cost-effective tool, I mean, that's the best of both worlds, right? It's funny. I was talking to one of my partners. He's a little older and he's been doing green lights. He doesn't do anything else. And it's something frustrating kind of trying to tell him, hey, just venture and try, one of these other things and someone else, just don't use a cookie cutter approach because, there's more than one way of skinning a cat. So the only takeaway in that regard, I would say is, just feel comfortable being quote unquote a little adventurous about trying new techniques and, they might surprise you the way they did to me. So.
Hello, everyone, and welcome back to BackTable Urology podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at BackTable.com. This is Jose Silva as your host this week. I am happy to introduce our guest to Dr. Francisco Gelpi, or Gelpi, better known as Paco. Paco and I go way back. We both went to the same high school. I actually graduated 2 years before him. He spent also a year in college over in Boston, and he went back to Puerto Rico. He did med school in Puerto Rico, same time that I did, and then residency. So it's a funny story. Actually, Paco got accepted to urology residency in Puerto Rico, and I was in general surgery. So when Paco decided to go to Thomas Jefferson, he got transferred to Thomas Jefferson, basically. Paco, can you chip in on this and give your version of the story?
You forgot two things before that. First of all, you forgot that I used to play tennis with your sisters, your twin sisters.
True. I remember.
And this one you probably never knew, but I was actually a patient of your mom. So there's more connections that you actually. So yeah, so the funny story, funny, not funny, but it's that when I was a resident back in Puerto Rico, I had been looking for the potential to transfer to a different place, have something, a bit of a different experience. And the opportunity came along in Philadelphia at Jefferson. When that happened, my position was actually then given to Oche. We kind of like worked it in a way that it actually ended up working perfectly. But the backstory is that you had suggested to look at Jefferson, and I called them after a night that I was on call, and the lady that responded, it's like, why are you calling us? We just happened to have an opening that came available yesterday. And I told her that you had mentioned it about it and whatnot. So I go through the process, get there, and then I go to you and I tell you, hey, dude, I got transferred to Jefferson. And you're like, yeah, that's good. But I thought it was Penn State that I had told you. So by total accident, I ended up calling a different program in Pennsylvania and happened to transfer there. And that's where I did my residency.
Exactly. So you spent there, was this 5 years or 6 years?
It was so in total, it was a 6-year program, just like the one that we had in Puerto Rico,
Okay.
2 years of general surgery, but I transferred as a PGY3.
Okay. So then afterwards, you did your Oncology Fellowship over at Mass General at Harvard?
Yes, so I did a Uro-Oncology Fellowship. It is a combined program with Mass General and the Brigham. It's affiliated with Dana-Farber. 2 years of cancer research. I also happened to get out of that a master's in public health from Harvard as well.
That was actually your first couple of months you started doing that, right?
Yeah, so when you go there, the first summer is supposed to be this program in clinical effectiveness, and it accounted for about a third of the master's of public health. So I just figured if I'm here and I can get this done, why not go for the whole thing? So I negotiated with my mentors that if I could turn every class into a publication, which I ended up doing, then they gave me permission to sit for the MPH. And it was crazy, but I got it done in a year.
And what are you doing with your MPH now? Same as mine?
Absolutely nothing, my friend.
I did mine prior to going to med school, but yeah.
No, but remember, at that time, I was gung-ho. I want to stay in academics. I want to be part of the next generation of teachers and mentors. And then during that time, my daughter, the eldest, who's 11 now, she was diagnosed with epilepsy when I was just starting my fellowship. So that was sort of the eureka moment for me where I said, you know what, as much as I love this, I cannot dedicate my life to my job, which was the case at that point. And I just said that, okay, family first. And I just figured that, and I mean, no disrespect to the people that are in academics. I'm not by any means saying that they cannot do both. It's just that at that time, I needed to be available 24/7 for my family should something happen.
And that's what throw you to a more private practice setting. And you ended up, you're now in Houston as a private urologist in a group there.
So I'm in Houston with a private practice group here. We're the largest private practice group in the city. And it was basically that ability to have full liberty as far as how I could use my time. There was no restrictions as far as, hey, it's an eat what you kill model. So it was all entirely, on me, and I didn't have to satisfy any requirements. And that's why I gravitated to that. I mean, is it the perfect job? It's not. I don't think there's a perfect job out there, but we're happy enough here. We've grown very fond of the city, and yeah, we're here for the long haul.
Good. So yeah, I mean, we talk often, and you definitely tell me your experience as a private urologist. I'm employed. I'm in private, but employed, and it has different perks. I have good things, bad things, but like you mentioned, there's no perfect job. You make the most out of it, I guess. So Paco, so when you first started, I mean, you ended up this oncology residency or your oncology fellowship. When you joined the group, were you gonna be the oncology guy? That's was the idea. What? How was the process?
So it was pretty cool in the sense that there was no pressure to do so. I am in the west part of town. We basically have 9 offices spread throughout the city. I am not in the med center. I specifically wanted to avoid the med center. And the pod that I joined, they were pretty chill about, you can do whatever you want. We'll support you. And I guess at the beginning, my idea was, I can try and absorb as much of those oncology cases that no one else wanted to do, or things that were a little more complex and challenging. And, instead of sending them out to the med center or a place like, we have the benefit of having MD Anderson and Baylor and all those, fine institutions here. So I kind of was, offering to my partners, hey, if you want, I mean, I'd be more than happy to give it a crack. And it's so been that I've tried and keep my oncology percentage of the practice at about 30% or so. I do robotic cases every week. I just did a partial today. I have 2 lined up for next week. So it's not like it's the only thing I do, but I still do a fair number of it. And just 2 weeks ago, I was doing an IVT thrombectomy. We do, the RPLMDs every now and then. I do cystectomies with my partner. But at the same time, it's been a process of learning that as much as I love it, the reality is it's not the most cost-effective part of urology, and hence I've decided to supplement it with doing other things that I am very fond of and that I've sort of developed a very deep interest for.
And now you are a center of excellence for Boston Scientific in the BPH department, right?
Yeah, so that was a very interesting trajectory because so when I got here, I had never done a single green light, and I happened to train at a place where we did a ridiculous amount of HOLEPs, home laser enucleations of the prostate. And what I ended up doing was, okay, how can I adapt the techniques that I learned from something that it's not really, it's not readily available right now because there's been so many issues with utilizing a morcellator that I ended up, it sounds like almost creating a new way of doing green lights, and that took off and it drew the interest of the reps. And then from that, we jumped to Rezum and then Eurolift, and now I do a good number of these cases. We became the one of the first center of excellence, combined center of excellence for Rezum and GreenLight, and I just became proctor for both procedures as well.
So Paco, so in terms of the green light, Are you the only one within the group that was doing it or started doing it? No one in the group was doing it?
So I was fortunate that when I joined the group, there is a one of those, great minds in BPA in the BPH world. His name is Dr. Ricardo Gonzalez. He used to be my partner, and I actually learned quite a bit from him while he was here. I do have a number of other partners that do them, but they don't feel as comfortable in tackling, bigger glands. And, I just did today a 170-gram gland. And I did another one yesterday that was about 50 grams. So we'll walk, I guess at some point we'll discuss a little what is sort of like my algorithm, but it's sort of become my go-to, my tweeze knife, sort of like procedure for BPH.
No, I didn't know you were with Dr. Gonzalez. Yeah, I definitely have seen his videos and those glands. So I try to emulate that same technique. So Paco, so a patient goes to your office. He's having some voiding issues. How's the process of, or how do you evaluate that patient? You do a US symptom score. What's the process when a patient walks into your office?
So I have that's something that's changed drastically in the last 2 years, and let me elaborate on that. So prior to that 2 year mark, I guess I was doing what I think most of us did, which was you come in, you get a UA, you probably get a PVR, a flow, you get the symptom score, and then you'd had a conversation with the guy and get them on medication, and hey, I'll see you in a couple of weeks, a couple of months, and then we'll go from there. About 2 years ago, I met a practitioner from the Northeast who basically said, hey, when a patient comes to see you, you need to offer something different than the primary care physician. And hence, you are the protector of the bladder, and your focus should be changing the nature of that conversation into how to protect the lower urinary tracts as much as possible. That really resonated with me, and I tried to copy his way of doing things. And now anyone that comes in with symptoms, basically gets, yes, we get a symptom score, we have a conversation, but most of them end up getting some sort of lower urinary tract imaging. I typically do pelvic ultrasounds, because most of my patients are Hispanic and they hate the
Yeah.
transrectal ultrasounds. So what I do is I have it set up in a way that we own an ASC, and we get the cystoscopy done, and then they immediately are moved into our imaging center. They get the pelvic ultrasound. Now we have incorporated Eurocuff, which I'm not saying that everyone needs to get a Eurocuff, but it's also one of those things that we can throw in the middle. And then we get back together with all those things and decide, hey, are your urinary tracts at risk of, compromising your upper tracts? Do you want to consider medications? Do you want to consider an intervention? And that's kind of how the conversation goes. But it's more than anything, again, focusing on bladder health and bladder function preservation.
So your cystoscopies, you're not doing them in the OR. I mean, in the office. You're doing the in the ASC.
So that's a very touchy subject with my practice right now because we had the ability to do them in the office. I am hopeful that we can go back to that, but in a way to try and incentivize people from using our surgery center, our I call it the mothership. All of that equipment was moved away from the offices, and hence you kind of have to centralize everything. So I had to kind of like get creative about how to make as much as I could in the same patient's visit, so that they would not get a little frustrated. It's a very again, it's a very hot topic right now in my practice. I am trying to recover a couple of those things being done in the office. I just purchased the Pronux machine with the intention of bringing my Urolifts and Rezums to the office. So yeah, chances are by the time this thing airs, it might be a different story. But right now, I'm still doing them at that facility.
So the idea would be to use the Pronux machine for the cystoscopy as well, just for the diagnostic.
Yeah, I mean, but Pronux, and I don't know if you are familiarized with it.
I'm actually not familiar. Yeah, no.
So Pronux is again at the suggestion of another friend from another practice, which by the way, it's part of my personality. I'm always trying to innovate and look for new things and so forth. Pronux is basically a patient administered nitrous oxide device. The beauty of it is that it's a 50-50 mixture between oxygen and nitrous oxide. You basically don't require any licenses, certifications, nothing. It's all the responsibility of the patient. Obviously, there is some monitoring involved, but the reality is it's a very simple way of having a patient very comfortable at the time of doing any of these office-based procedures, vasectomies, urolifts, trusses, prostate biopsies. Any of these things are perfect for this mode of anesthesia. And yeah, and we've been running with it for the last couple of weeks, and so far I absolutely love it.
Because definitely, I found myself having more issues. I do them in the office, the cystoscopy, but every time I get more push from the patient. No, no, without anesthesia, without anesthesia. Even though I use the Eurojet and the numbing agents, still just every month there's people that trying to push it. So hopefully we're trying to get the Pronux in the office, and that way maybe I can do more cystoscopies instead of just like you mentioned, doing the flow max and coming back in 4 weeks to see how you're doing.
But I will tell you that the eureka moment for me there was just having the I guess the audacity of changing a little the way that the conversation takes place. Because once you explain them, I show them. I have a lot of pictures in my office. I show them, hey, this is what a normal bladder looks like. This is what a decompensated bladder looks like. You don't want to be there. So you kind of get patients engaged into, no, I want to know, I want to know. So as far as the Pronux for the cystos, I'm not saying it's an absolute must, but yeah, every now and then you're going to have that guy that I want to be comfortable. I actually encourage them to be awake because I want to show them, hey, this is what your anatomy looks like. So, and then they kind of go back and, oh yeah, that looks like that picture you showed me in the office. So, but it's all a matter of the conversation. And just to give you numbers, all across the board in my practice, the BPH patient that walks in turns into a procedure in probably about 5% of cases. And that's been looked at. I've managed to get that now closer to 50%, and it keeps going up.
50.
It's 50.
Wow.
So it's just a matter of having the conversation. I never ever tell them, I don't want to push them into getting a surgery. I don't want to, have them leave the office thinking, hey, I absolutely need to get something done. But, if you're young, healthy, you want to prevent those, nasty sexual side effects.
Yeah.
Yeah, I mean, all that stuff. Again, it's a very interesting conversation that I've learned how to have now, and it's completely different to the one that I used to have when I finished training.
So Paco, definitely that's very important. The bladder health. We never talk about that, and for me, when I started doing Eurolift, I think that's what they started pushing. Hey, the patient needs to be aware of that bladder health. Just that it can continue to get worse, worse, worse. So I mean, I try to incorporate, but yeah, I need to do a better job on that. So Paco, in terms of so you do the Eurocough, you show the patient, hey, you're obstructed. How's the process in terms of deciding whether you do a Eurolift, a GreenLight, a Rezum? How do you do that?
So again, it's a very involved conversation with the guy, right? I need to be very very emphatic about the importance of setting expectations, right? So when you have these conversations, what is the priority for the patient? Is it just bladder health? Is it getting rid of the nasty side effects of the medication? Do they want to preserve the ability to ejaculate? Is it not that big of a deal for them? So there's a number of different layers to that conversation. In order to simplify it as much as possible, right? The way I kind of think about it is when I do a cysto, I'm trying to gauge, okay, does this guy have any sort of median lobe, or is this guy only obstructed, with bilobar obstruction? Then it gets to the component of, okay, what is the size of this prostate? And, I will tell you, I've tackled, for instance, with Rezum, prostates that I know that are larger than what's supposed to be done. But you have the conversation with the patient, you explain them, hey, this might be pushing the envelope, and, if they're willing to give it a shot, yeah, we might give it a couple more, injections than we otherwise would have. So, but again, in order to simplify it, I normally think if it's bilobar and it's shorter, or I'm sorry, it's smaller than 80 grams, I typically prefer a Eurolift. I like the Urolift a lot because it's a very easy way of getting a patient to stop medications, leave the ASC and be happy, not need a catheter, and basically start experiencing improvement of symptoms almost immediately. If there is a central gland slash a median lobe, then it all depends on how protuberant that is. I've started doing some of these urolifts with the median lobe, but my preferred option for the younger guy with a smaller than say 80-gram prostate is probably going to be Rezum. Now, Rezum, it's interesting because I think it's a great tool, but you have to be very careful how you sell that procedure to the patient, because you have to be clear that, hey, things are going to get worse before they get better. And if they don't, even better. But it likely is that they will have a number of weeks that they're going to be uncomfortable. The way I handle that, everyone goes on anti-inflammatories for a week or two. Everyone goes on stool softeners. Everyone keeps a catheter for about a week. That was one of my mistakes at the beginning. I probably left it for a little shorter than I should have. So, but once you start revisiting and refining these things, you explain to them and they're fine. And then anything larger than that, in particular, if there's a large protuberant median lobe, it's likely going to be a GreenLight, unless it's someone that is open to the option of, say, robotic simple prostatectomy, which I normally reserve for those very, very intravesical median lobes that you can just get the procedure done so much quicker than being there for a while with the GreenLight. So that's it in a nutshell, how I kind of like think and navigate these things.
So you mentioned about the medications you give the patients. Do you usually give the same for Rezum, Urolift, and GreenLight patients?
Yeah, I had to simplify it so that my scheduler, because she used to, mess things up big time. So any procedure that I do for the prostate in that regard, it's always the three, it's Colace, it's Pyridium and Meloxy Cam. I
Yeah, I
I mean,
got that from Dr. Gonzalez.
Mhm.
That's what he recommends, and that's what I use.
I think it makes a huge difference, particularly the anti-inflammatory part of it. So I've been doing it now for a while. Why Meloxy Cam and not others? I mean, it's just because it's the one that people typically like here in Houston.
Are you doing the 50 milligrams once daily, or 7.5 twice daily?
It depends on the age, but normally the 7.5 daily, if they are older, and I'm a little concerned about their renal function. If they're younger, that I give them the full 15 and they do perfectly fine.
So I started doing back in Puerto Rico. I started doing 7.5 twice daily, just cause. I mean, no specific reason. I was actually Castillo, the one who started doing it, and I just
Oh,
copied.
nice. Okay.
Yeah,
Okay.
but I mean, it's the same thing.
Yeah, it's just to help them with that inflammatory phase that everyone's going to go through that, right? So
So when you're doing your lift, do you so you once you're there, you put, I mean, 2 4 clips for implants. If one is misplaced and it goes into the bladder neck, are you using a grasper? How do you go about that?
yeah, normally a grasper.
And you try to twist it first and see if you can reposition it.
Yeah, but I mean, and I think this is probably the number one mistake that we all make when we are learning how to do Urolift, right? We're used to seeing that very white bladder neck that you normally get with, say, a TURP or a GreenLight, right? And this thing is not designed to mimic that. It's designed basically to protect the bladder neck. So at the beginning, I was firing them maybe a little too close to the bladder neck. So every now and then I had to go back in, remove them, and put a new one. We've I guess we've finally figured out that, hey, you need to go a little farther than that. Whatever your mind tells you it's okay, and by doing that, you're kind of like protecting yourself from yourself. And yeah, that's which is interesting. When I first started doing Eurolifts, I'm not saying that I had bad results. I actually had pretty decent results, but I was only utilizing 4 implants because that's what was the most cost effective in the ASC. So then I had to kind of get a little creative about that. And what we do is we have a facility that it's basically run as an ASC, but it's not a formal surgery center. So then we can bill as if we are in the office, and then that allowed me to use more implants, and hence the cost effectiveness of the procedure improved. So now I feel that I get better results, because if you have that guy that you're debating, do I put only 4 or do I go for the additional 2 and put 6? money is not that big of a deal. You just want the guy to pee right. And that took me a while to kind of like, figure out and master. But yeah, I'd say the sweet spot's usually going to be somewhere between 4 and 6. Very seldomly I would put more than 6. I feel that if I have to do that, chances are I am selecting the wrong procedure.
And you're doing fully on a specific case, like bleeding or something, or you haven't had that in a while?
At the beginning, maybe we had a little more of that bleeding. I think that their numbers, and it's pretty much mimics what I typically see is, basically only 1 in 10 guys, if anything, are going to go home with a catheter. But for the most part, they all go home without a Foley.
Good. Yeah, me too. So yeah, I started with Foley, and then I quickly I changed to without the Foley, and maybe I haven't had any retention afterwards. That first night is horrible for the patients, but then afterwards they really do better.
But again, you set up the expectations, right? You
Exactly.
tell
Yeah.
them, yeah.
Yeah. Hey, probably you're not gonna sleep tonight. Just be aware of it. Yeah.
Don't call me. No, I'm just
Yeah.
kidding.
So Paco, so for Rezum, you mentioned the intravesical component of that medium lobe. Is there a threshold of how big are you gonna tackle that median lobe? Is it a matter of size or how you see it when you do the cystoscopy? How do you decide that part?
So Resume is what I call the leap of faith procedure, right? Because you do it, and I mean, I'm sure that this happens to you and probably everyone else that's listening, right? You do the case and you're like, holy moly, please work, because you really don't see anything major that's happening right in front of you that tells you, hey, this is gonna work.
No, it actually looks worse.
Yeah, if anything,
Honest.
yeah.
Yeah.
So what I typically do is, again, that's why I've sort of like utilized that 80 gram threshold. And don't get me wrong, I think the largest that I treated was, and I'm hoping this doesn't get me in trouble, but I think the largest I treated was like 130 gram, and the guy's doing perfectly fine. But normally, in order for me to find sort of like a happy medium where, okay, if you have enough tissue, I don't want to overdo it and get overconfident, it's between 80 and 90 grams. When I do the cysto, obviously I'm looking for how much of that component to that central or medial lobe is present. And then I kind of start, planning, okay, is this going to be just one needle stick in the central gland? Am I going to do like two, one on each side? The way that I sell this procedure to guys, I tell them, hey, we are trying to deflate your prostate. And I kind of look at it that way, man. After, I don't know if you've ever had to scope any of these guys.
I haven't. I started
It's
doing
impressive.
recently, so I still I mean, they're doing very good, but I haven't had to scope them again for now.
Oh no, it's impressive. I had a guy in particular that he kept having irritated symptoms, and we did the Euroflow, we then did the Eurocuff, no signs of obstruction, but he continued insisting that he was obstructed. And when I put the scope in, I mean, the thing was completely deflated. So yeah, that's why I'm saying it's a leap of faith case. Again, you have to set up expectations very clear from the get go. I normally joke with them that, hey, you're gonna love me, then you're gonna hate me, and then you're gonna love me again. So there's a component of hand holding and giving them peace of mind, but it works. And the right guy, I think it's a great tool.
And that patient is still complaining of irritation, or he's doing good?
No, he's doing fine. I mean, again, this is a very complex conversation. I get it. It's a very abstract thing for patients to understand, right? You're basically telling them, hey, you've been an athlete for all your life, and all of a sudden you're going to sit that guy. He wants to go back to get out there, and that's what happens to your bladder. Your bladder kind of gets a little unstable, and you just need to allow for the remodeling phase to take place, and the symptoms calm down. But it took a while, and he finally got it.
Exactly, and yeah, some patients do develop that overactivity even with I mean with green light with all symptoms, but it's just like you mentioned, it's just that part of the bladder are readjusting as to the openness that they're gonna have now. So Pago, in terms of treatments, I know the reps always stress, hey, don't overtreat the prostate. I mean, you always think, hey, maybe the more treatments we do, the better it is. But definitely that those irritative symptoms, at least on the data, suggest that the more is not it's not better.
Yeah, so I will tell you one thing that I learned from Eurolift, and I mean, what I'm gonna explain in a second. It's a little abstract, so bear with me. But the whole premise of Urolift is creating that anterior channel, right? So going back to our training, we're all of the idea that, hey, I have to, do that TURP that will resect every last bit of tissue so that, it's an open and wide as possible, right? But the reality is you don't need to do that. The diameter of the urethra basically will dictate the flow. So why do we need to make this very large, posterior fossa, get it all well resected if it's going to funnel into whatever the diameter of the urethra is? So I've sort of incorporated some of those ideas into the way that I do my green lights, into the way that I do my resumes. So yes, when I do a green light, do I want it to be completely wide open? Of course, but I really concentrate or focus on making an anterior channel that kind of mimics what the Urolift would have done. And going back to your point, by being a little more selective and specific in that regard, the amount of irritated symptoms that I've seen in the last year or two have plummeted. And it's just because, you want to do good enough that you get them to pee, that they're comfortable, they have a good flow. You don't want to overdo it with it. And now you have to deal with that, nasty bleeding that could happen, or that burning or stinging that they sometimes complain about when you're a little too aggressive. So yeah, little things that you kind of start changing as far as technique. And it's basically helped me drastically.
And when you do the green light, are you doing the channels at 5 at 7 and then going down to the Veromontanon and then resecting medium lobe and then lateral lobes?
So I do something that I'm sure you very likely that you haven't seen something like it, because it's kind of like using the hold up technique where you would create these sort of like channels at 5 and 7. And then I connect those and I enucleate that middle portion with the beak of the scope. And then when I leave that tissue hanging, I then blast it with 180. And I mean, again, prostate from today, perfect example, 170 grams. Most of it was a median lobe. Procedure took me 15, 16 minutes, because most of what I do is concentrate on that median lobe, enucleate using the scope as if it was my finger. And then by the time you're done, the stuff on the sides, yes, you shave it off, but you don't have to be overly aggressive. Once you've done that, those incisions which mimic the transurethral incisions of the prostate, and then you take that valve-like mechanism of the median lobe. I mean, those guys are going to pee like a champ.
And you go down to the channels in 150 and then 180 to the middle?
Actually, no, I do my channels with 80 because I am very, very cognizant of the irritated symptoms they can get when you mess up the bladder neck and anything in the vicinity of the trigone. So I make the channels with 80. I connect them with 80. And then that's the part probably that's the hardest to explain in something like this, which is not visual. But that's when, once you are able to disarticulate that piece of tissue. I mean, this thing, if you're in the right place, in the right layer, this thing just peels off. Just like when you're doing an open simple, right? And then I just allow that tissue to sit there, and I aim away from the floor of the prostate so that I'm not causing any of that burning. And that tissue in the middle just disappears. It's pretty cool.
Wow, but that's very impressive. 15 to 16 minutes, 170 gram.
I mean, again, it's a guy that I pick him up because I know that most of it's a median lobe, and that's what I'm going to have to work on hard, right? So if you have a guy that's 170 and it's all lateral lobes, you're going to be there till tomorrow.
And you mentioned, you mentioned for the Rezum, you leave the catheter for a week, but for GreenLight, just overnight?
Yeah, I think what happened was it had to do with the way that my clinic was set up. So all of my partners typically do it for 1 day. I'm kind of OCD. I keep it for 2. Do I have any data for that? Not really. It's just the way that it worked for me. Same as most of these guys. I don't know in your office, but I probably see 60% of my patients are Hispanic, and they don't like the idea of removing the Foley at home, so they come to the office. So, and I think what happened was that I normally do these cases on Mondays, and Wednesdays there was a opening for my MA to kind of handle those, and that's the way it worked out. But yeah, and to kind of like go back and just give you an idea of how long I keep Foleys and so forth. Uroliths normally nothing. Resumes, when I started, it was 3 to 5 days. Now, at the very least, 1 week. And then GreenLights, it's usually 2 days. If I do a robotic simple, I typically keep it about a week. I normally don't do any cystograms. I've never had any leak. There was a guy that was miserable with it. I did the cystogram at 3 days and the bladder was perfectly fine. So we pull it out. So, but I feel that a week is more than enough for not only the bladder to heal, but also for those bleeders at the prostate fossa to kind of like, all clot and not cause any issues moving forward.
And in terms of the green light, you mentioned the lateral lobes. So how far up? Because sometimes I run into trouble when I start going maybe at the lateral lobe, but if there's a very tall lateral lobes, you go like in the middle, and then the upper part falls like a roof that is like a ceiling.
So that's where the whole lip technique, it's very helpful for me, right? Because when we did whole lips, at least the way that I learned it from Dr. Das, who was our mentor at Jefferson, we would originally do our 5 and 7 incisions for the median lobe, and then you would make a 1 o'clock and 11 o'clock incision on the sides, and then when you follow that, the lateral tissue just falls down, it plops down. And I use that to my advantage because, as I mentioned before, now I'm not super worried about having to remove all that stuff. So I want to lower it and shave it enough so that I create a good channel, but not really trying to get into that, meat of the prostate, the 5 and 7, where you're probably going to get into some bleeding. I typically always leave for the end, all that the tissue in the vicinity of the oh my god, the verbotentum. I call that the knuckles. I typically leave that for the end, and I normally lower the energy there again because if you get in the right spot, I mean it's perfect. But if you mess up some of that deeper tissue, it's going to start bleeding. And yeah, but I mean, what I would say, yes, in that case is instead of just eyeballing it, just find that edge of the lobe, which is usually at 1 and 11, and once you get there, it just plops down.
Sometimes you're like torquing a lot the cystoscope. You don't know how much torque you're gonna put in it. You're
Mhm.
very very high on the prostate, an area that maybe visually you're not seeing anything. It's just water flowing, and sometimes it's really hard to say where you're at if you don't know the area. And in your case, because maybe you had that exposure to the whole lip, but that area usually when you're doing TERPs, for example, that you never go that high.
Exactly. No, no, and that's something that again, I just happen to have the benefit of learning HOLEP and figuring out how to disart. That's the word that we kept using, using in residency. It was you want to disarticulate it, and the reason you do so is because it puts you in that plane that you're not really going to bleed a whole lot. So, but like anything else, there's 100 ways to skin a cat. This is what makes sense to me. I've managed to turn it into a way that I can do it with a number of these guys and feel comfortable that the guys are going to go home and I'm minimizing risk and so forth. And yeah, I mean, am I always kind of like trying to learn and improve the technique? Absolutely. I mean, you keep learning little tricks, here and there.
And Paco, you mentioned the simple prostatectomy. You also mentioned a big glands or big intravesical component. So those patients, the size wouldn't matter. It's actually how the prostate looks intravesically, or also big glands more than 200, 250. Would you do a simple prostatectomy?
No, I've actually done simples in guys that have smaller prostates than that. I mean, I think the smallest that I probably taken to a simple was probably in the order of 120, 130. But it was all intravesical protrusion. So, when again, you sit down with the guy and I told him, I can be there with this laser and hopefully I can take care of this, or I can do this other approach and make sure that I'm going to get it all from the inside. And, it's a matter of them really deciding what resonates the most with them. But yeah, when you have those very intravesical protrusions, man, it's awesome because you can really remove a substantial amount of tissue. The other guy that I would say that makes sense is when you have, and I just had this case a couple of months ago, a guy with a history of elevated PSA. He had some high grade pin. He was very nervous about his PSA. So I told him that, we were going to not only address his lower urinary tract symptoms, that I also wanted to handle some of that prostate tissue. And interestingly, his PSA kind of like normalized for his age, and it was because of the sheer amount of tissue that we managed to remove. So
And in that patient, would you do a biopsy first?
yeah, so he had an MRI. He was referred by one of my partners. After I started doing these things, you start generating a little traction, and then partners that don't feel comfortable, that, hey, why don't you handle this guy? That guy from today, as a matter of fact, it's a patient of one of my partners. By the time that they come and see me, they usually have an MRI, which I kind of use as a way of comparing to, okay, what do my measurements tell me? Is it compatible with what the MRI is saying? Am I seeing something that is, very much protruding into the bladder? So, but yeah, it's one of those things that you can never go back and say, hey, there were two cases that were identical. There's always little nuances about one and the other, and again, I what I like about the way that I do it right now is that the fact that we're center of excellence for Rezum and GreenLight, hopefully soon for Urolift. But I put them in a room where they see all these posters. So I tell them, hey, I'm not married to any of these things. I just want to figure out which is the one that makes the most sense to you. And when you kind of put it that way, I feel that they kind of trust you even more, because I don't want to be the guy that, hey, I go to bed with, Boston Scientific just because I am their proctor. And it's a pretty cool process that I'm sure you also have to go through, because we are not trained to think this way when we are in residency, right?
Exactly.
So yeah, it's been an interesting path.
Good. And definitely patients, they're better. I mean, they want, they're asking for more simple procedures, more bladder neck sparing, or at least more less sexual side effects, no retro ejaculation. They want that. Some of them, they don't want to take medications. They're looking for something more permanent in that sense, or just one thing and done. And like you mentioned, I mean, you're going to start doing procedures in the office, and I think that's because that's the way you're always heading, at least in this BPH scenario, doing more stuff in the office, more cost efficient, less copay for the patient as well. And yeah, I guess that's where we're heading.
Now that you mentioned the whole sexual side effects, so that was a big part of this, by the way. Me getting involved in things that I had never done, because again, when you and I train, there was no Urolift, there was no Resume.
GreenLight just started.
Had just started, but the energy was not that good. And
Exactly.
and again, I trained with literally zero green lights. But one thing I was going to say, I had a very uncomfortable situation with a patient a couple years ago, where this guy was young, maybe 55. He comes in full blown urinary retention. So I scope him, massive, medium, low. I don't recall now the size of his prostate, but it was closer to 100, 120 grams. And we talk about the options. I did a green light. Guy comes back, he's peeing like a champ. And then he comes for his post-op, I think 3 months later, and he basically accuses me of stealing his manhood. So I sit down with him and I'm like, what are you talking about? And he's like, yeah, I'm not ejaculating. And I'm like, are you not experiencing the pleasure associated with it? No, I'm not seeing the white stuff. And I sat down with him and I told him, hey, we talked about it. Yeah, you mentioned it, but I didn't know it was going to be like that. And, it got heated. He almost punches me, and, it turned to something, very aggressive, right? I had to fire the guy from the practice and whatnot. But it was sort of an experience that I had to learn from, because now when guys come in, I mean, they sometimes, they tell me, like, why are you spending so much time talking to me about these sexual side effects? And it's because it's a reality. I mean, these things can happen. And I have guys that I tell them, if ejaculation is the most important thing for you, then we're definitely not going to do the most aggressive. And again, a heavy Hispanic population where that's part of their manhood. And I have to, what started almost like something to laugh about, it's a very important part of the way that I conduct my business. And that's how I looked into these other alternatives at the beginning.
And that's exactly right. I had a patient, same scenario. He had a Foley catheter. I did a green light. At that time, I wasn't doing a Rezum or any Urolift. He's being great. But yeah, he comes, hey, I'm worried about this. I said, hey, I told you that's not going to come back. He started crying. I said, well, are you trying to have kids? No. Okay, well, But yeah, we sometimes think about just the obstruction and really not think about that part. And now with all these new tools, it's something real and for younger patients is great. I mean, you don't even have to worry about that as well as long as they fit.
Exactly.
That is gonna work. So Paco, any takeaway message? Anything you want to add to this?
No, what I would say is, as far as BPH goes, this is not rocket science. Again, I kind of gravitated to it because I had a particular interest in the laser technologies that were out there, and I felt that it was a way of really helping these guys. And yeah, the span of just a couple of months, we managed to achieve center of excellence, proctorship and stuff, and it's a really integral part of urology. And if you can find a way, that happy medium where you're doing something that's really helping someone and it's also a cost-effective tool, that's the best of both worlds, right? It's funny. I was talking to one of my partners. He's a little older and he's fixed and doing green lights. He doesn't do anything else. And it's something frustrating kind of trying to tell him, hey, just venture and try, one of these other things and someone else, just don't use a cookie cutter approach because, there's more than one way of skinning a cat. So the only takeaway in that regard, I would say is, just feel comfortable being quote unquote a little adventurous about trying new techniques, and, they might surprise you the way they did to me. So
True, that's exactly right. So Paco, thanks for being in BackTable. Definitely the best of luck. I mean, you're doing great. You're moving forward, creating new things over there. Congratulations with the Center of Excellence. You mentioned the Eurolife is coming, so again, congratulations, and we'll keep in touch.
absolutely, dude.
Okay.
It was a pleasure. Yeah. Un placer, campeón.
Gracias, Paco. Take care, man. Have a good night.
Yeah, you too. Ciao, ciao.